Welcome to Med-Surg. Welcome to Med-Surg. Welcome to Med-Surg. Welcome to Med-Surg. This is the orientation that every new nurse deserves, but almost no one gets. Now, I'm Nurse Key, and I've been a nurse for 6 years, started off as an LPN, and now I'm RN, working her way through NP school. If you're a new nurse and nobody has explained this to you, this is the series for you. Now, first, let me say very clearly, Med-Surg is not basic nursing. Med-Surg is not a starter unit, and Med-Surg is not where nurses go because they're not good enough for anything else. Med-Surg is a specialty all by itself, so let's put some respect on it, okay? Med-Surg is where nurses learn how to think. Now, Med-Surg nursing is the backbone of the hospital. You are caring for multiple patients, right? Sometimes 6 to 8 patients at a time with multiple diagnoses at different stages of illness and all at the same time. You are managing medication, assessments, lab, procedures, family questions, documentations, and unexpected changes, often with limited time and limited resources. This unit is not about doing one thing well. It's about managing complexity safely, competently, and accurately. While most new nurses come into Med-Surg thinking the job is about tasks, passing meds, doing dressings, starting IVs, checking boxes, but that's not actually the job. The real job of a Med-Surg nurse is risk management. You're constantly asking yourself, is this patient stable? Is there change expected? Can this wait, or does this need action right now? The tasks are what you do, but clinical judgment is what actually protects your patient and your license. Med-Surg teaches you how to prioritize when everything feels important. It teaches you how to recognize early deterioration before it becomes a crisis. It teaches you how to communicate clearly with providers and how to delegate appropriately and how to document in a way that protects your license. If you can manage Med-Surg safely, you can work anywhere because that is your foundation. If you're on Med-Surg and you're feeling overwhelmed, that does not mean that you're failing. That does not mean that you're not good enough. It just means that you're learning how to do nursing safely. ICU nurses start here. ER nurses start here. Travel nurses start here. Leaders start here. Med-Surg is not where nurses get stuck. It's where nurses get strong. And even if you don't leave Med-Surg, there's nothing wrong with that. Continue to build your foundation and see what works for you. But if you are in Med-Surg, don't feel like that is your last resort or that's not good enough. It is more than enough, and Med-Surg is needed. So this is a series where we are going to do the Med-Surg orientation that you should receive on day 1. We're going to break down how to think, how to prioritize, and how to speak like a nurse, and how to keep your patients and your license safe. This is not about perfection. This is about confidence through understanding. So welcome to Med-Surg. Let's build your foundation. Get ready for video 2. Oh, and by the way, this requires class participation. We are not just learning, we are engaging, and we are becoming the nurses of our dreams. Now, if that sounds like you, and you are on Med-Surg or you are a new nurse, and you're like, I need a roadmap of where I need to go with this thing, link is in the bio. The New Nurse Fast Track, this is our class resource. We are not only going to show up for work, we are going to be prepared. We are going to be knowledgeable of our topics, our skills, and our clinical judgment, right? So this book shows you everything that you're going to be exposed to in your first year of nursing. So follow along, get ready, get prepared, and get ready to learn. Welcome to Med-Surg. This is the orientation that every new nurse deserves and almost no one gets. If you're a nurse and you're trying to figure it out, this series is for you. Hey, my name is Nurse Key, and I'm a registered nurse. I've been a nurse for 6 years, starting off as an LPN, now an RN, and I'm working my way through NP school. Let's talk about understanding your role on the Med-Surg care team. So one of the biggest reasons new nurses feel overwhelmed on the Med-Surg unit is because no one ever really clearly explains your role. So you walk on the unit and suddenly you're expected to do everything and anything, right? Answer everything and manage everyone. But Med-Surg nursing is not about doing everyone's job. It's actually knowing about what your responsibility is and owning it. Now, as a Med-Surg nurse, you are the clinical coordinator of care. You are the person who sees the full picture. You're responsible for assessing your patients, identifying changes, prioritizing care, administering medications easily, and communicating concerns to the appropriate team member. You are not just carrying out orders. You are not babysitting. You are interpreting what is happening to your patient, delegating certain tasks, and you are coordinating with the higher level of care providers to intervene and get the appropriate care plans for your patient. So Med-Surg is a team environment, but every role is different. Providers diagnose and prescribe. The pharmacy verifies and supports medication safety. Respiratory therapy, they will manage advanced respiratory care. Physical and occupational therapy focuses on mobility and function. And CNA support basic patient care, including assistance with activities of daily living. But you are the coordination of it all. You decide what happens now, what can wait, and what needs escalation. Now, let's talk about delegation versus dumping. Delegation is not dumping tasks onto someone else. Delegation means that you assign appropriate tasks while maintaining accountability for the outcome. You also delegate based on that person's level of orientation, their capacity, and the level of resources available to that person. So you can delegate tasks, but you cannot delegate responsibility. At the end of the day, the nurse is going to have to oversee all the things that were delegated and make sure that they were completed effectively and safely for the patient. So if something goes wrong with the patient, the question will always come back to the nurse. Now, common role confusion for new nurses. New nurses often feel pulled in every direction because they don't yet trust their judgment, and to be quite honest, seasoned nurses do too. However, again, you have to build systems for your practice. You have to understand what's available to you and what is actually a priority in that moment. So often new nurses try to say yes to everything. They try to fix everything and they burn out quickly. Again, this can apply to seasoned nurses and people just in general, right? We sometimes are people pleasers. We overextend ourselves, but you have to learn boundaries, accountability, and delegation needs, right? Your job is not to be everywhere at once. Your job is to keep your patients safe within that time that you have, the resources that you have in your own mental and physical capacity. Now, how do we shift into the nurse mindset? When you start to think like a nurse, your questions change and your actions follow. You stop asking, what do they want me to do? And you start asking, what does my patient need right now? This is the shift where confidence begins. But it doesn't happen without preparing and understanding what's in front of you, and then setting systems and boundaries in place. So, understanding your role is the first step to actually managing Med-Surg safely. In the next video, we're actually going to go over the scope of practice and knowing your limits to actually make you a stronger nurse. So, welcome to Med-Surg. Let's keep building. And by the way, if you have not checked out the new nurse fast track guide, you need to go to the link in my bio, because I'm not just teaching on TikTok or social media. I'm actually putting in the work, and I've already created something for new nurses. Oftentimes after nursing school, new nurses do not have the roadmap of what a new, safe, and competent nurse looks like, and I figured we're not going to keep having that, right? So the new nurse fast track, it actually covers everything you need to know within your first year that you will be exposed to at the bedside. Get it today. Welcome to Med-Surg. This is the orientation that every new nurse deserves, but one they rarely get. If you're a new nurse and no one explained this to you, this is a series for you. Hey, my name is Nurse Key. I've been a nurse for 6 years. I'm currently a registered nurse. I started off as an LPN. Now I'm an RN, and I'm working my way to an NP. All right, so today we're going to talk about the scope of practice on a Med-Surg unit. What is your responsibility and what is not? So one of the biggest reasons new nurses feel overwhelmed on a Med-Surg unit is because no one clearly explains your scope of practice. The scope of practice is not about what you can do. It is about what you are legally and professionally responsible for and expected to accomplish. So when your scope is unclear, nurses either hesitate when they shouldn't, or they do too much when they should not. As a Med-Surg nurse, your responsibility falls into the nursing process. Now, I have a video on the scope of practice, depending on if you're LPN or RN, but I could review it really quick. So the nursing process generally falls into the assessment, diagnosis, planning, intervention, and evaluation of a patient. Now, if you're an LPN, you know that you don't do the initial assessment of a patient. There's some medications that you don't push, like IV push, and no blood transfusions. Now, RNs, they encompass the full nursing process. Okay, however, on a Med-Surg unit, There are certain practices that you would not do, let's say if you were on an ICU unit or step down or ED. Every unit has their own set of practices, policies that each nurse must know and abide to, just to protect your patient, yourself, and your license, right? So in Med-Surg, this is your lane. You're responsible for assessing the patient, recognizing changes, identifying risk, and responding appropriately. You're not responsible for diagnosing the disease. You're not responsible for choosing advanced medical treatments, but you are responsible for recognizing when something is no longer safe. That is the thing. On a Med-Surg unit, you generally have a blend of all different diagnoses, all different surgical procedures, right? You get post-op patients and you get chronically diagnosed patients generally. That means that they could either come from the ED, and this is a chronic problem, which means it's over 6 weeks that this problem has been occurring, or they have been stepped down either from ICU, step down unit, and now you have them, and they have now been stabilized. And so now they're closer to being discharged. This is the patients that usually you find on a Med-Surg unit. Now we know in today's age, these patients in general are more sicker, and so Med-Surg units sometimes have step down level patients, right? But as the job of you as the nurse is to recognize, hey, what does stable look like for this patient? Recognizing when there's a status change of when this person is declining, escalating it, and getting them the appropriate care that they need. Or if this patient is stable and then ready to be discharged, also communicating that to the appropriate source. So what Med-Surg nurses are not to do. This is where new nurses can get confused. Med-Surg nurses typically do not titrate IV medications the way ICU nurses do. Generally, on a Med-Surg unit, you're going to give IV medications that consist of antibiotics. It may even be some cardiac medicine, but it's not where you're going to continue to increase or decrease the dose rate. You're going to spike the bag, you're going to hang it, it's going to run, and then you'll discontinue it. So if you see a medication that looks like it requires titration, that's really not your job within that scope generally on a Med-Surg unit. Your job is to clarify the order, the parameters, and escalate it appropriate. So even if you're getting a new admission, it is your job, because usually you don't get report on new admissions now on these units if it's coming from the ED. So you're supposed to review that chart. The charge nurse will do that as well, but you'll review the chart, see what medications are running, see if it's appropriate for the scope of your unit. If it seems like it's too like it should be going to a higher level of care, whether it's step down or ICU, you're supposed to report that to your charge nurse and say, hey, I don't think this falls within our unit. This person may need to be transferred to a different unit. So your job is really to kind of base on your instinct and your knowledge of what's within your scope. Doing more than your scope does not make you a better nurse. It actually puts your license at risk and your patient. The reality on Med-Surg units, BLS versus ACLS. So BLS, basic life support, whereas ACLS, advanced cardiac life support, BLS is expected on a Med-Surg unit. So that's like our general compressions and defibrillation. ACLS involves a lot of cardiac and advanced medication to be given during that cycle. So Med-Surg units, if you find a patient. Now, ACLS is performed by the code team or trained responders, depending on your facility. So if something critical happens, you don't have to freeze trying to remember the ACLS algorithms. You start BLS, activate the emergency response system, and you have done your job. Now, let's talk about any critical status changes and when to escalate. So this is the rule for keeping your patients safe. Any critical status change requires escalation. Let's say, of course, the obvious is if they're found unresponsive, but also respiratory distress, their blood pressure starts to tank and it won't come back up. This means that you have to activate rapid response and you notify the provider. What this looks like is you are trending your patient's vitals, you are trending their appearance, you are trending their pain levels, and their overall demeanor. When things start to go left, That means when they start to decline, you get ahead of things. You say, hey, provider, I noticed that when they came in, this was their baseline, these are their vitals, this is what their labs look like. Then all of a sudden they're becoming more lethargic, their blood pressure is going down. What would you suggest? So when you start to see something, you say something and you get ahead of it. Now, let's say the patient continued to decline all the way down throughout the day. Now you're like, hey, this is definitely becoming a problem. You should activate rapid response. And notify the provider. Both are going to matter because recognizing change and acting on it is your responsibility as a nurse. Now let's give a real clinical situation. Respiratory status change. So your patient comes in, this is 7 a.m. You come in, you get a report. This patient is on room air. They're alert and oriented ×4. They're walkie-talkie. That's what I call it, right? Now, initially when you do your first morning set of vitals, they're on room air. They're sitting at 100%. Then all of a sudden, they're taking a nap. They wake up. The next check, now they're sitting at 96. Okay. Then they continue to kind of go down. You wake them up. They're fully alert again. They're continuing to go down a little bit. They're 93, 94. You put O2 on 2 liters, right? Because start 2 liters nasal cannula. That bumps them up to 96, 97. Okay, we're within normal limits. You walk out of the room, you're doing your rounds, you come back again. On 2 liters now, they have dropped down to 93, 94. They're still alert, but they're needing more respiratory assistance. So you bump it up to 4 and maybe 6, just depending on how they respond to the advanced oxygen. Now, on a Med-Surg unit, 2 liters is already... Oxygen is considered a medication, right? But generally, in some hospitals, now check your policy, you're able to start 2 liters of oxygen. But as you continue to see that they need advanced oxygen needs, that's telling you something is going on with this patient. Even if they're still alert, oriented ×4, there's something else going on. So when you continue to increase, you need to be notifying the provider, hey, this person is requiring more oxygen needs. This is their past medical history. This is what they came in for. What do you suggest? Now, let's say you go to 6 liters. Now, when you return, you check that they have desatted, and now they are becoming more lethargic. It's taking more assistance to get them to wake up. You have already notified the provider. Now this person is lethargic or now non-responsive. You are going to activate a rapid response. Rapid response means that you are going to call somebody on the rapid team. They are going to come to the bedside, assess this person. Now they're going to talk back and forth to the provider. Hey, this person may need a BiPAP. This person may need to be intubated based on the clinical picture that I'm seeing. As the nurse, you have done your job because you have trended throughout the day. You have intervened with appropriate interventions, and you have escalated to the provider. But unfortunately, the patient hasn't positively responded to your interventions. So now higher level of care has now been requested. So rapid response, again, they'll come in and now they're going to intervene on your patient's behalf. It's almost like not that they have taken over care, but they're like the bridge between Med-Surg unit to a higher level, right? And they're now going to coordinate care between the doctor, and they can have certain orders put in place a little bit quicker than you at the bedside can have. So it's not your job to decide what treatment will come first. It is your job to coordinate the care, communicate what clinical picture your patient is presenting at the bedside, communicate with that provider and tell them, hey, I think higher level of care or resources are needed for this patient, and tell them why. You have to recognize that a level of care has changed. That is your main job as your nurse, along with providing the care plan for your patient. Now, this all falls into knowing your unit's limit. I always suggest that people look at your unit policy and procedures book that's located on every unit, and it says this is the scope of your unit. When a patient's oxygen demand keeps increasing and they can no longer be safely supported on your level of care that the unit provides, this is no longer included in the scope of care on a typical Med-Surg unit. That could include a continuous BiPAP, intubation, right? You cannot support an intubated patient on a Med-Surg unit, especially with the ratios as they are right now. So that's your cue. You assess, you recognize the trend, and you escalate. I want you to hear this clearly. Escalating does not mean that you have failed. It just means that you did your job. Your job as a med-surg nurse is to proceed with the nursing process for your stable patients. When they begin to get unstable, escalate it. If they are stable continuously, discharge them. That's the flow of a med-surg nurse. Keep them stable. If they become unstable, escalate to transfer. If they continue to be stable, go ahead and discharge. That's the workflow. So I want you to hear this clearly. Escalating does not mean that you failed. It means that you did your job. Patients don't deteriorate because nurses call for help too easily. They deteriorate when nurses wait too long. So this is why I created the New Nurse Fast Track. It walks you through how to recognize status changes, understand your scope, and escalate safely without panic. If you want that support with you on the floor, this is the link in my bio. In the next video, we're going to talk about nurse to patient ratios and time reality, because understanding your workload changes how you practice. Welcome to Med-Surg. Let's keep building. Welcome to Med-Surg, and this is the orientation that every new nurse deserves but rarely gets. My name is Nurse Key. I've been a nurse for 6 years. I'm currently an RN, started off as an LPN, and now working my way through NP school. So if you're a new nurse and nobody has ever explained this to you, this series is for you. So this video, we're going to talk about nurse to patient ratios in Med-Surg. All right, so let me explain Med-Surg patient ratios in a way that actually makes sense. Every patient, let's say you have even 6 patients at one time on a Med-Surg unit. And when I worked a Med-Surg unit, we had up to 6. Each patient has different needs, personalities, and different levels of supervision or acuity that's needed. One might be sleeping quietly, one might need help right now, one might be fine until they're not. But you're responsible for them all at once, at the same time, in 8 or 12-hour time span. So let's talk real numbers, because this is not theory. This is real life. So like I said, in New York, we have up to 8 patients at a time. Georgia, around 6 patients at a time. And in California, where they have nurse to patient staff ratios, theirs is mandated and is typically up to 5 patients in a shift. The difference matters because the more patients that you have, the less time you physically have for each one. So when you're managing 5 to 6 to 8 patients, you're not just doing tasks. You are constantly switching focus. You are answering call lights, reassessing pain, giving medications, you're charting, and you're responding to changes. So when you feel like you can't give everyone equal attention, it's not because you're failing. It's just because Med-Surg nursing is controlled chaos. So here's some hard truths. You generally cannot nurse 6 to 8 patients the same way at a time. You can't. Nursing is not about fairness, it's about priority. The patient who is the most unstable is going to get the most of your time. Even if another patient is physically louder, more impatient, or frustrated, it's about the more complex acuity of that patient at the moment. So safe medical surgical nurses are constantly asking themselves, which patient needs me now? Which patient can wait? Who is at risk of deteriorating? This is not cutting corners, this is managing risk. So new nurses burn out when they think they're being overwhelmed because they're not cut out for this, but not realizing that this is how the system is set up. You're overwhelmed because you have 6 to 8 patients and they're all asking for your attention, while you have to focus on the priority and still try to manage their personalities and feelings behind it. So new nurses, they'll tend to skip breaks, they'll stay late, and they try to be everything for everyone. No nurse can give 8 patients ICU level attention. It just is not possible. You're expecting yourself to do this, and this is what is exhausting you. Have realistic expectations. Being able to assess your patient, intervene, and evaluate them requires systems. It requires delegation, and it requires accountability. When you come onto the shift, you have to have a system. You have to plan your day in ahead of time. You have to set the tone with your patients. Let them know, hey, this is the plan for the day. This is how the day is going to fluctuate. You set them up with what they need beforehand, whether it's snacks, food, water. Give them the call light. Say, hey, if you do have to get up to go to the bathroom or anything like that, press the call light. I will be around with your medications. Give them a set schedule. That way they know, okay, they're not by themselves in these things. They kind of have expectations of how the day will flow. That generally helps to set the tone. That's not always perfect, but at least it is a good start. So, burnout, right? Escalation also matters. When one of your patients suddenly needs constant attention, you cannot just ignore the rest and hope for the best. This is where escalation comes in. You have to call for help. This is going to be the charge nurse, rapid response team, and the provider. This is how the system works safely. You have to escalate your concerns to the proper source to get safe treatment plans for your patient at that time, and not think that you have to manage it by yourself. Now, this is exactly what I break down in the new nurse fast track. I've been a nurse for 6 years, but I've had unsavory experiences being a new nurse, and I just feel like after nursing school, you're kind of left to fend for yourself, right? This is one of the jobs where they say you'll learn it on the job, but unfortunately on the job you're not learning everything you need, so it leads to burnout, insecurity, and unsafe practices as a nurse. So I built a new nurse fast track to cover everything a new nurse will be exposed to and act upon in the first year of nursing. So let's face it, the first year of being a nurse is going to be difficult, but it doesn't have to be so difficult that you'll quit within the first 30 days. And let's be honest, we all have had those moments, right? And that's because we're not being taught properly. So the link is in the bio. Get it today. Catch back up for the next video. And if you haven't liked and followed my page, go ahead and like it now, because you need to see the next video in this Med-Surg orientation, okay?